virus. Bacterial is the Streptococcus pneumoniae is the most common. Haemophilus influenzae, Moxilla catarrhalis, Staphylococcus aureus, Staphylococcus pyogenes is least one. But however, if it's happened, it is very severe, especially the MRSA. Fungal mucormycosis and different kind of aspergillosis. Odontogenic infection is a kind of infection that originates from the teeth. There is a special bacterial like Streptococcus bacterium, which is high resistance to antibiotics and the presence of the anaerobic antibiotics. The classification of rhinosinusitis is acute, less than 4 weeks. Chronic rhinosinusitis, more than 12 weeks. Recurrent acute is greater than four or more episodes of acute rhinosinusitis in 1 year. Between them, there is more than each episode is lasting from 7 to 10 days, and there is complete resolution of symptoms between each attack. Acute exacerbations of a chronic, with the symptoms of chronic rhinosinusitis, it's sudden worsening of the symptoms, and then they return to the baseline of their treatment. History, it depends on the history, it depends on the each types. Physical examination, we need to do the anterior rhinoscopy, headlight and the nasal speculum. So either this is the Thompson, this is the pediculum. In the posterior rhinoscopy, we're using the endoscope, either rigid or flexible. Again, we need to assess the mucopurulent discharge along the nasal floor, middle meatus, you need to assess it, draining above the inferior turbinate or above the middle turbinate, hyperemia or edema or allergic signs. Again, you need to see the nasal pathology. Is there a septal deflection or septal deviation? Is there a polyps or there is narrowing of the osteometal complex? This is the clear post-nasal drips. This is coming from the above the turbinate, above middle turbinate. This is coming from the below middle turbinate. And this is a mucopurulent discharge clearly. Again, this is a mucopurulent complex with erythema and hyperemia of the osteometal complex completely. CT scan indication, again, it's the same indication. MRI indication, also the same indications. This is again the sagittal, the coronal cut. This is the inferior turbinate. This is middle turbinate, and this is the septum. You can see the osteometal complex is completely obstructed with complete ossification of the maxillary sinus and extending to the anterior ethmoid. This is the MRI. You can see the bones and you can see the fluid, presence of the fluid. Usually the wound is poorly differentiated in the MRI. That's why we don't use it for differentiation of bones. What to investigate? Usually we need the CT scan. This is the gold standard for the pre-op assessment and general assessment of the diagnosis. MRI, the same indication, orbit, intracranial, or the bone invasion. Biopsy, the bone invasion for the bone marrow, okay? Biopsy, if there's any suspicious tumor, especially unilateral or adult nasal biopsy, then tumor, you can do it, but mainly you can do it before, you can do the biopsy after the CT scan or MRI. Acute rhinosinusitis is sinonasal inflammation, again, that lasts 4 weeks, associated with sudden onset of symptoms. Symptoms must include both. In the 4 options, 2 they have together. Nasal blockage, obstruction, congestion, or nasal discharge. One of these, and facial pain, pressure, or reduction or loss of smell. اوكي يعني بالمحصله من الاربعه هذه لازم 2 يطلعون هنا عندهم نفس السيمبتومز. If you have these symptoms, 2 of 4, this is indication of acute rhinosinusitis. You can diagnose the patient with acute rhinosinusitis. Radiological and endoscopy are not required for the diagnosis of acute rhinosinusitis. The pathogen, it is started typically by viral upper respiratory tract infection that persists longer than 10 days. It starts with the swelling of the nasal mucosa and then the blockage of osteometal complex. Then the blockage cannot drain the mucociliary drainage back. Then it will have a stagnation will happen. After stagnation will happen, the infection will come over the stagnation because of the humid area, and the patient will go into bacterial rhinosinusitis. The resistance pattern, Streptococcus pneumoniae is 25%, Haemophilus influenzae 30%. Almost all strains of Moxilla catarrhalis, they have resistance. So the antibiotic choices depend on the severity and the age of the patient, plus the duration of the treatments. It should not be less than 10 days. I have seen patients, they have been given antibiotic for only 7 days, which is not recommended for the acute rhinosinusitis. Antibiotic, you can start with augmentin, or you can use the cefuroxime or cefidemir for less severe infection. In cases of patient allergic to lactam, you can use the Bactrim or doxycycline or any kind of macrolides, plus the nasal decongestant, 5 to 10 days, maximum 5 days. Nasal irrigation, it is cornerstone to irrigate all the stagnations and fluid out of the sinuses and the mucosa. And then you need to use the intranasal steroid to eliminate the inflammation. The criteria of chronic rhinosinusitis, that is persistence more than 12 weeks, and symptom must include at least 2 of the following. The same way of acute rhinosinusitis: nasal blockage, obstruction, nasal discharge, facial pain, or pressure. You can choose any of these 4, okay, for the patient. In the acute, you have to combine 2 plus 2, okay. Additionally, for the chronic, you have to have evidence of inflammation on the paranasal sinus by CT scan, or evidence of purulence discharge coming from the sinuses by the scope. So 1 of these plus 2 of these. So the chronic rhinosinusitis, it can be divided into chronic rhinonasal sinusitis with nasal polyposis or without nasal polyposis, based on the presence or absence of nasal polyps. And criteria of diagnosis is clear or la? Okay. Chronic rhinosinusitis with nasal polyposis, you have to treat the patient maximum medical treatment. We got intranasal steroid, nasal irrigation, oral antibiotic, then oral steroid for 3 weeks. If all these fail, patient can go into endoscopic sinus surgery. Plus, sometimes we need to prepare the patient for the sinus surgery by using the oral steroid. So again, the natural history chronic rhinosinusitis of nasal polypi, they have a chronic disease in 80% of the patients, especially the recurrent type. So usually they have the asthma, or we call it the SAMTRA triad, which is aspirin intolerance, asthma, and the nasal polyposis. 3 triads, SAMTRA triad or disease: aspirin intolerance, nasal polyposis, and asthma. It's again the same description: grape-like mass, smooth surface, pale and yellowish, insensitive to touch, protruding through the middle superior meatus part. It is part of the chronic rhinosinusitis. Histopathologically, usually it's called allergic because of the eosinophilic presence, with constitution of 90% of nasal polyposis. Usually there is presence of edema, goblet cells with hyperplasia of epithelium, thickening of basement membrane, numerous leukocyte, minimal vascularity, no ending. That's why it's insensitive to touch. What are the differential diagnoses? Polypoidal middle turbinate, inverted papilloma, meningeocele, angiofibroma, and malignancy. Not all nasal masses is kind of nasal polyposis. You have to differential diagnosis them. Again, the treatment of chronic rhinosinusitis is intranasal steroid, systemic steroid, oral antibiotic, and then surgery. Viral rhinosinusitis, it's spread by the infected droplets. ما فهمت سؤالك. ما فهمت سؤالك يا مشعل. كيف how many of
يعني
which are malignant؟
في differential diagnoses اخذناهن كلهن، كم النسبة انه يكون malignant يعني؟ او كم منهن يكون malignant؟
It's depend on the history. بشكل عام generally speaking malignancy of the nose and nasal sinuses is less common. Okay, but differential diagnosis for the antinasal tumors, in the top differential diagnosis is the nasal polyposis. Then we have the polypoid with the turbinate inverted papilloma, meningocele, angiofibroma, and malignancy. However, how you stratify the differential diagnosis, it depends on the patient complaint scenario. So you cannot make nasal polyposis in the top of differential diagnosis in like 70 years old patient with unilateral mass that is bleed, easily bleeding, hybremic, with destruction or numbness on the face. This is in clear indication or clear idea this is aggressive tumor. واضح كلامي؟ يعني but an idea because of the lecture of chronic rhinosinusitis, we don't need to making your thinking is very narrow. We have to think broad. So viral rhinosinusitis, we have the 3 stages, which is the dry prodromal initial stage, or then they have the catarrhal stage, then you have the mucus stage. Dry prodromal, nasal dryness and irritation, low-grade fever, chills, general malaise. Then the patient go to catarrhal stage, which is a clear watery discharge, rhinorrhea, sometimes anosmia because of the congestion, lacrimation, and sometimes worsening of constitutional symptoms. Then after that, the patient goes to the mucus stage, which is thick rhinorrhea, greenish, foul smelling, that's indicating the infection, and improved constitutional symptoms at the rate of mucus stage. Treatment is only supportive treatment. Sometimes we need to give antibiotic in cases of secondary bacterial infection. The site of pain in sinusitis in the maxillary, usually infraorbital maxillary teeth, and referred vitalgia to the ears. Ethmoid, usually medial canthus and the nasal dorsum. Frontal, usually in the supraorbital, and bitemporal, sometimes the occipital. The bitemporal, you have to differentiate that from the migraine headache. Sphenoid, usually in the vertex of the skull. Chronic rhinosinusitis is defined again into inflammatory condition of nasal cavity, paranasal sinus that's lasting more than 12 weeks. Usually there's multifactorial factors between genetic, environment, and host anatomies. The meaning of host anatomies, that's like septal deviation, which is going to take it in the next lecture. Sinusitis in children usually is associated with adenitis and recurrent tonsillitis. Usually they present with nasal obstruction, virulent rhinorrhea, cough that is particularly worsening at the night, foul breathing. Usually there is periorbital edema that's worsening upon the wake up. Sinus pain is not prominent feature in the children. Complication, it's very highly likely to happen in the pediatric age group, especially the orbital complication because of the very thin lamina pubracia. Usually the same bacterial, bacterial treatment is the same of acute rhinosinusitis. So there's 2 important factors for the 2 important landmark for the sinusitis in children, which is the cough, particularly that's worsening at the night, and the periorbital edema that's worsening upon the wake up. Fungal, the mostly common accepted fungal system classification system is the invasive and non-invasive. In invasive type, we have acute invasive fulminant, which is very fatal and lethal, granulomatous invasive, and the chronic invasive fungal rhinosinusitis. The non-invasive, we have the saprophytic fungal infestation, fungal bowl, and the fungus-related eosinophilic rhinosinusitis and allergic fungal rhinosinusitis. The acute invasive usually is patient with immunocompromised status, present within 4 weeks. If there is sometime paresthesis, necrotic nasal mucosa, and hard palate. Sometimes it goes directly to the blindness and septic shock. Histopathological, you need to see the invasion on the histopathology. sometimes it goes through the carotid artery, cavernous sinus, vasculitis and the thrombosis and hemorrhage and tissue infarction, even in the major arteries. Who's in risk for invasive? Again, neutrophil dysfunction, neutrophils such as hematological disease, such as aplastic anemia, uncontrolled diabetes mellitus, hemochondritis, and the patient who is in chemotherapeutic agent, plus the transplantation patient. Cost of organism, mucormycosis is in the top, Aspergillus species also second. Treatment, which is top emergency, patient need to go to ICU admission, antifungal, systematic, and sometimes we need to debride the patient locally. So the criteria of diagnosis, which is they called it the Bint and Cont criteria, is the presence of type 1 hypersensitivity, and then there is presence of nasal polyposis, and there's characteristic radiological finding, which we'll talk about it, and there is eosinophilic mucus demonstration fungus without tissue invasion in histopathology. The treatment, surgical, with post-operative systemic steroid and immunotherapy. We don't give antifungal for the allergic fungal rhinosinusitis. This is what we call the double density sign. You can see the hypo and hyperdense in the CT scan on both sides. There's thinning of the nasal bone, thinning of the bones without any invasions. You can see clearly here the polyposis. So the fungal ball is development of non-invasive fungal hyphae into the mass, like this one. Aspergillus is the most common pathogen, usually happen in the humid area in the older people. From the chronic rhinosinusitis, because the body start to fight this one, it caused the chronic rhinosinusitis that is leading to the paranasal obstructions and nose obstructions. Treatment, you need to completely remove it, intranasal steroid and nasal irrigation to clear all the sinuses discharges. The complication of rhinosinusitis incidence decreased since the use of antibiotic, but however, there is three main categories: orbital, intracranial, and bony. The orbital is the most common, mucocele and mucobiocele, orbital infection. The intracranial, meningitis and the intracranial abscess. Bony, which is a butt-puffy tumor, and the frontocutaneous fistula, which is very, very rare. Orbital complication of sinusitis, which is called Chandler classification, which is the grade 1 is lid edema, which is the presence of infection in the orbital septum, which is preorbital septum. Orbital cellulitis is infection of the soft tissue in the posterior to the orbital septum. Subperiosteal abscess, which is pus collection beneath the periosteum of lamina bibracea. Orbital abscess is pus collection in the orbit, associated with limitation of extraocular movement, sometimes presence of exophthalmos and visual changes. Cavernous sinus thrombosis is bilateral eyes and meningeal signs. This is the subperiosteal abscess. You can see clearly subperiosteal abscess with exophthalmos and the swelling of the eyes. The intracranial complication, extradural abscess, subdural abscess, meningitis, encephalitis, frontal lobe abscess, and osteomyelitis, which is butt-puffy tumor, which is subperiosteal abscess in the frontal bone. Mucocele, it is a mucus filled inside the cyst due to obstruction drainage of the sinus or retention cyst of mucus inside that closed cyst. Expansion, remodeling, because it's still collecting, so it's pressure. It causes pressure necrosis around the area. treatment, you need to endoscopically marsupialize the sinus, the cyst. The antroquinal polyps is kind of a special polyps. It arises from the maxillary sinus. It goes through the prolapse through the ostium. It goes posterior through middle meatus. There is a theory of bacterial infection. It causes rhinorrhea and progressive nasal obstruction in unilateral more than in bilateral. Usually smooth, pale, and soft, maybe not visible by the anterior rhinoscopy because it's caused posteriorly. The management of antroquinal polyps, you need to endoscope the nose completely from the anterior to the posterior. Sometimes you need to confirm it by the CT scan. This is one piece polyps. Then you have to endoscopically remove that mass completely. The odontogenic infection, it's infection of the maxillary sinus through the maxillary root teeth. Clinical presentation, usually it's present through unilateral nasal discharge with nasal symptoms, very bad smell, history of dental surgery or poor dental hygiene, sometimes no significant history of dental pathology. However, pain overlying the sinuses is clear indication. Diagnosis, you need to do the anterior rhinoscopy to see the mucopurulent discharge, nasal obstruction, nasal discharge, and the status of ostomeatal complex. Usually the bacteria is anaerobic and spirochetus. Radiological CT scan we needed to see the dental root of the teeth inside the maxillary sinus or the osteo or the fistula from the maxillary to teeth. Again, the odontogenic, you need to give them broad spectrum antibiotics. Sometimes you need to endoscopic sinus surgery to clear all the sinus and discharge. And you need to refer the patient back to the dentist to close and cement the area of the fistula. And sometimes you need to use the intranasal steroid. Sinus surgery, after the maximum medical treatment, which is defined as 4 weeks of appropriate antibiotic, nasal steroid, and general systematic steroid therapy, plus the nasal irrigation. Surgical treatment is now optional or indicated in these failed cases. The idea of function is to just remove the diseased mucosa and not to remove all the normal tissue. Endoscopic, why? Because of excellent visualization. Function is to restore function. We keep just the patency. We restore the patency and keep all the normal mucosa and just open the sinus. 90% symptoms improved after the surgery. There is usually TV or a large screen for the surgeon to watch the surgery. That's it. This is the only slide that you need. Complication of endoscopic sinus surgery. Adhesion is the most one complication, and the most feared one is the retroorbital hematoma or hemorrhage is the most feared complication. Any question?